This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hi, everyone. Welcome to She's on Call. I'm Dr. Marina Kurian, and I'm a general surgeon that does minimally invasive surgery, weight loss surgery in New York City. And today is a first, actually, for us. Even though we started the program back in June, it's the first time that Sujana and I are not co-hosting. But it's going to be a wonderful show. We're going to talk about obesity and different ways to deal with obesity and overweight issues. And we're going to do that with Dr. Reem Sharaiha, who is a clinical associate professor in medicine and GI at Weill Cornell here in New York City. As well, we're going to talk to Dr. Paul Davidson, who is a clinical psychologist and director of behavioral services for the Center for Metabolic and Bariatric Surgery at Brigham and Women's Hospital. And we're going to talk about obesity from a lot of different angles. But as you guys know, we're going to get to some of the news of the week first, and we have a fair amount to talk about. First, we're going to talk, the CDC here in the US has actually issued some new travel guidelines, which is great because people are going to be able to visit their grandparents, their parents. I mean, we've heard such wonderful stories of how people are, after a year or two going to visit their families and actually touch their grandkids and not just on Zoom or on FaceTime. So in the US, domestic travel, you can travel domestically and if you're fully vaccinated, and also international travel depends on where you're going, whether you need a COVID test before you go, but it's not required by the US to do it. And then when you come back, if you're fully vaccinated, you do not need to self-quarantine unless your state requires it. So when they're coming to the US, though, you have to have a negative COVID test before they board the flight or get a COVID test 3 to 5 days after returning from international travel. So this is really an improvement over the things that we've had to do. And I think it's also great because, some of the quarantine rules are going to be different. One of the other things, and you guys who are watching, thank you so much. I see people tuning in from all over. We are live on Facebook and YouTube as well. We are live on Sri Srinivasan's LinkedIn channel. And if you're watching, you can hit like and share so that this is a great topic. It's very temporal, and we're going to get to that in a minute, but also want to give an update on what the vaccines are doing. So in the US, we're at nearly 20% fully vaccinated. Unfortunately, there are many countries they may not even get to this point this year. And that's unfortunate. It has to do a lot with distribution of vaccines and not necessarily vaccine hesitancy, which is, again, as I said, it's very unfortunate. The other thing that I think is very important to point out is that while we have these vaccines, people are very concerned about the variants that are out there of the vaccines. And we have a great slide that we can show you that the B117 is the UK variant, B1351 is the South African variant, and P1 is the Brazilian variant. But you can see that for most of these variants, there's still a fair amount of efficacy against the coronavirus. So even if it's one of the variants of coronavirus, there seems to be a fair amount of efficacy. And so I think that that's good news. And again, as Sujana and I both love to say, the vaccine that you should get is the one you can get. So don't wait for another vaccine. And it's, the issues with Pfizer, Moderna, and Johnson & Johnson, again, saying that they have different efficacy. The point is that these are all 100% efficacious at preventing death from coronavirus. And that's the reason that we should get the vaccines in. Okay, you guys, so that is all I have, except for one thing, one great point. New York has over 36% of our population in New York State has gotten the vaccine already, which is a little higher than nationally, but I still think it's a great, something that all the states hopefully will shoot for. And we are going to talk with our great guests. We're so excited to have them. Again, you guys, we're going to be talking about obesity and treatments for that, as well as behavioral health, as well as procedures and surgery. And our guests are Dr. Reem Sharaiha, who's Assistant Professor of Medicine and Gastroenterology at Weill Cornell here in New York, and also Dr. Paul Davidson, who's a clinical psychologist, Director of Behavioral Services for the Center for Metabolic and Bariatric Surgery at Brigham and Women's Hospital in Boston. Welcome. Thank you so much for joining me.
Thank you for having us.
Thank you. This is going to be a wonderful show. I'm so excited to have you guys. Is business back to normal for both of you? Because it's I feel like it's probably still a little slow. It's it's medicine, and it's interesting that we are all treating obesity from different angles, and COVID-19 and the pandemic and the quarantine certainly affected that, right? And we've also seen that the coronavirus having obesity is a serious risk factor for having a more severe illness. So I would have expected that all of us should be really very busy right now. And I'm just wondering how it is for you guys.
Certainly at Brigham Women's, we are very busy. As we're aware, elective surgeries were put on hold at different times, and there was a lot of pent-up demand that built up. And as we also know, as a result of COVID and continuing stress, that's led to significant weight gain for a lot of folks. We have more people who are interested in getting surgery. And I do think one of the benefits of the fact that obesity is a significant factor in COVID is that more attention is being paid to the treatment of obesity. So we have more people focused on that. So yeah, we're wildly busy. And I will also say the ability to do things virtually has been a game changer. We have many people who are able to participate from all over the country in ways they might not have been able to before. So we're hopping.
Completely agree. Since we started introducing surgery again and endoscopy again back in May of last year, we've seen an uptick in patients coming to see us. And as you said, I think with COVID, everyone gained that COVID 15 or 19, and a lot more people are interested in pursuing treatments for obesity, being medicine, surgery, or endoscopy.
I was in a little bit of denial about how much weight people have gained. In recently, our producers, we were all chatting, and somebody said, well, just saw an article that it was 25 pounds. I was like, no way. I talk to my patients all the time. No one's gained 25 pounds. That's wrong. And of course, there's a study out there that says that people during the quarantine were gaining 0.6 pounds every 10 days. So that's almost 2 pounds a month. And, it's close to 25 pounds in the year. And I was wondering why to myself. I was like, why is this that I wasn't seeing so much? And of course, they're weight loss patients, but they're also patients that are out longer from surgery. So there was some weight regain. And I think, for us, it's about, I would say 10 pounds. And usually patients are gaining in an average year, people gain about 1 to 2 pounds, and they might go up more than that during the year, but they tend to realize like, oh, hey, I gained 5 pounds. I'm going to try and work back on it. But this whole block of Groundhog Day every day has been a problem.
Yeah, completely agree. It's sort of the repetition of being at home, not being able to walk, especially when there was the lockdowns in the first few months of last year, and people not having access to the gym, not knowing how you would contract coronavirus, and then not being able to test for it. So you were always in that cycle. And then although people would be able to cook from home, I think it's still watching TV, sitting down, being sedentary. I mean, I even noticed that even though I don't exercise every day. I walk a lot, and then just having sit down and do a lot of telemedicine visits definitely upped those pounds. So you had to have a conscious decision of really watching what you're eating, how much energy expenditure you're doing per day. And once I reset that, you kind of then reset yourself.
I want to talk, Paul, I want to get, let's pop up this slide of what it actually costs for our viewers. So, the weight loss industry is a big industry. And this is a slide I'd made for one of my talks, in the past year. And it's really saying that we're spending $60 billion annually on different programs. So the gym, weight loss programs, and then doing supplements. They threw in diet soda in there, but that's not actually a technique for weight loss, right? But $20 billion was spent on diet books, diet drugs, and weight loss procedures. So this is an interesting one. And then again, for our viewers, there's one other one, and we're going to talk about this, which is also about losing weight, and what happens each year. So this was what I was talking about, where usually people might gain 5 pounds, but they work on it to try and get down. But then what we see is that usually by the end of the year, there might be 1 or 2 pounds up, and that's something that they're, battling. Most of the people that are on these diets are female. And again, as I said, 20 billion are spent on diet books. There was a study that came out, and there's more than one of them, that talk about you need to do 1 hour of daily exercise if you're trying to keep off the weight that you've lost, right? So that's a lot. Like Reem, you said you walk a lot. Paul, same thing when we're going to see patients and you're up and you're walking around and you're rounding, you're doing all these things. Now you're not doing that. You're doing telerounds. And this is right here. The biggest walk you have is probably from here to the kitchen or the bathroom or your bedroom, and it makes a big difference in terms of our activity level.
Exactly. And the thing I was going to say too is that in our lifetimes, we have never seen such an ongoing stressful period, certainly not in this country. And when people are exposed to chronic stress, they start pumping out stress hormones. And ultimately, those hormones will feed an appetite. And the kind of things that we will wind up seeking are things that are going to give us rapid energy to deal with the fight or flight type of neurologic response. And that's usually going to be carbs. And I think, as Reem pointed out really nicely, since we have been much more isolated, in addition to not being able to go to places where people might have exercised, such as the gym, where they get a lot of encouragement from others, or working with a personal trainer, they're cut off from their social support network. And that only has added dramatically to people's sense of stress. And then when you get into that situation, you're more likely, since we're so close to the kitchen now, to turn to food, which is as you said, Marina, when I would be going to the hospital most of the time, I'm walking the halls all the time. I'm putting in 5-6 miles of walking a day. And when I'm just at home, there's much less of that. So you have to be more self-motivated. And I know Reem's motivated to do that. I'm pretty motivated to walk and stuff. But for many people, it's been a real serious challenge, and it's led to weight gain.
Yeah, and people are afraid to go outside and walk, right? Like, unless you live, like, I live in Manhattan, so does Reem. Like, we walk, we're going to encounter people as we're walking around. So there was also that fear of the unknown and of how, you're going to contract the disease. Like when you talked about in the beginning of this shutdown, even in January, they're like, well, the Chinese doctors are examining whether you can pick up coronavirus from surfaces. And that was like this whole phobia. Do not think I did not wash my fruit and veggies like in a little soapy water. You know what I mean? Like I did. I didn't know because we didn't know, so.
We did the same.
Yeah.
Same.
But Paul, how can we encourage people to stop beating themselves up about their weight gain? And how can we talk to them about initiating the first steps to get started? Like sometimes it feels like a mountain. You think, I have patients come in all the time and they say, and I'm sure Reem, you've heard the same, they're like, I have 80 pounds to lose. I'm like, let's start with 5. Let's work on the first 5 and then we'll go from there. Unless I'm operating on them, then I'm like, yeah, okay, we're gonna but if it's medical weight loss, they, or they've regained weight and they're like, I gained 50 pounds. I'm like, let's work on the first 5 and you're gonna feel encouraged to lose. But you have better strategies, Paul.
I think my strategies are probably somewhat similar to yours. And I think that one of the first things I do with and I work with obesity medicine patients, I work with endoscopic patients, I work with surgical patients. And one of the first things I try to do is help everyone who comes in to understand the fact that weight issues primarily are genetic. If we look at individuals who are struggling with obesity, chances are good that at least 70% of their weight will be accounted for by the genes. And as a result, there are biological reasons, as I mentioned, when we're dealing with coronavirus, we have a biological innate response to dealing with stress, and that's to protect ourselves. And by putting on weight, especially around the gut, we're protecting vital organs. And from an evolutionary perspective, that has been fantastic. And so I try to help people stop beating themselves up. As you mentioned that, because for the most part, this was something that over time had been a genetic issue that had been selected for. It helped keep people alive. So I think that's step number one, is helping them to understand that there are biological reasons why this happened. It is not a personal flaw or character defect. Number two, in terms of approaching weight loss, I'll give you a good example of this. I had a woman who had bariatric surgery, and I had seen her for a year. And she came back in, and she had suffered with weight regain, and she had gained 30 pounds, and she was so frustrated about this. And I tried to explain some of the factors. And I said, to tell you the truth, I'm not good enough to help you lose 30 pounds. I just don't have the strategies for you. But what I can do, I can help you lose 1 pound. And then we're going to do it 30 times. And she heard that, and all of a sudden, like, whoa, I could do that. And I think that's the way I approach things, is help, we're going to achieve great things by taking very small steps. So one of the first things that I think is useful for anyone approaching the need to try to lose some weight and get healthier. And that's the other thing too, Marina. I try to focus on improvement of health more than weight loss, because I know people who are thin and unhealthy and people who are heavy who are very healthy in many ways. But we all know, we're all in the business of helping people with weight loss, that if we can get somebody to a healthier place with less weight, they're going to do better. I think one of the other things that helps people to get going is to not be alone. So I think we always try to find somebody else in their life who can be a support person for them. It could be a parent, it could be a child, it could be a sibling, it could be a spouse, it could be a friend, it could be somebody who is associated with one of our programs. And so one of the things that we do is we immediately invite people to join in. We have a Facebook support group, and we have thousands of people who are actively helping one another. So getting engaged that way and finding other ways to reduce stress. So yes, we're going to be talking about the importance of physical activity. And I do use the term physical activity rather than exercise, because like diet, exercise has a bad rap with a lot of the people that we work with. We talk about activity. It's like they can do that and find things that people enjoy. I think that's the other thing. Find things people like. So dancing is something many people enjoy. They may not want to be on an elliptical, but walking is something people like. Sometimes swimming is something people like. Even movement in the chair. Finding something simple and small. Same thing is true. We start to deal with changes in diet and finding small ways to make those shifts. It might be starting to increase fluid. It might be starting to add a protein shake. Whatever it is that makes you start to move, because once you start to create movement, you're going to be very much on the path to success, because it's activity that is going to lead you to stay motivated. It is inactivity that is going to lead you to stay exactly where you are.
Wow, that's really well said, and great points. I love the 1 pound at a time. That is great. What about cognitive behavioral therapy? Can we talk a little bit about that? There have been some studies looking at CBT, cognitive behavioral therapy, and how it impacts our patients post-operatively, but it can also be used for other people who are not, surgical patients, let's say, right? And one of our viewers, Linda Lawrence, had just said that she, her employee health group was having Zoom meetings that are non-judgmental. I mean, that's wonderful, actually. Like an insurance plan would set that up for patients during this time. I mean, that's really kudos to them, and it's forward thinking, really wonderful. But let's flip back to CBT, Paul.
Sure. Yeah, happy to talk about it a bit. So when I had gone to graduate school ages ago, CBT was something that was a little bit newer. Now it's old hat, and we trained on a variety of different strategies. But cognitive behavioral therapy, this notion, it's really our cognitions, it's our thought that really has a lot to do with determining our behavior, was a major shift. Our field started with Sigmund Freud and the notion that people got stuck in places because of some kind of traumatic events they may have had, something that didn't go well early in their life, and you have to keep rehashing that. In the 1960s and 70s, behaviorists started to think, no, we're looking at conditioning. We look at patterns of reinforcement, and that somehow specific behaviors get reinforced. The famous study that was done with the salivating dog in, Pavlov's dog, in which he was trained to salivate when a bell rang, because you'd ring the bell, you'd give food, and the dog would be happy. You ring the bell, you give food, the dog gets happy, and pretty soon you didn't need the food. Well, the same thing happens in terms of things such as anxiety, and the same thing happens with regards to eating behaviors. For example, have any of you out there to think about going to the movies, back when we went to the movies, and it's like when you walk into the movie theater, what is one of the first things you're going to think of other than getting your ticket? Well, chances are good it's going to be popcorn.
And a drink.
What?
And a drink.
And a drink.
Or something.
It used to be Raisinets and Goobers and Jujubes, all those kind of things. People start thinking about food really quickly, and you would do something that you wouldn't ordinarily do. If I say, hey, you're going to go to work, went to church, a synagogue, or a mosque, the last thing you're thinking about is popcorn and a drink. We get conditioned to certain types of things. If I say, hey, you're going to be invited to a barbecue, you might start to think of hamburgers or hot dogs or corn on the cob or roasting marshmallows. We get conditioned to think of certain things. And so cognitive behavior therapy starts to help take those pieces apart and helps you analyze your thinking patterns. We have this notion of an antecedent, something that happens. We have a behavioral response, and then we have consequences of that. And we go into this loop over and over and over again. Where we try to engage people is before the behavior. And if you look at this graph, it shows the situation leads to certain thoughts, and those thoughts lead to both a physical behavior, and then that can lead you to emotions. And that then sparks action to either move towards something or away from something. So let's go to food for just a moment. So we have a situation in which we are stressed about a hard day, and we come home and we think, oh, I need to relax. So I'm going to have a drink, or I'm going to have, some kind of sweet treat or something like that. And then your physical response is to go and get those things. Then the emotional response can be, that made me feel better in the moment. But then afterwards, you start noticing, I'm starting to put on weight. I'm not starting to feel as good about myself. And so we start getting angry. And then what happens is we get upset. We take it out on ourselves and we engage in sabotage behavior where we'll repeat the same pattern again and again. So we need to find a way to think of intervening. When we're doing a cognitive behavioral treatment, oftentimes we look at what are known as behavior chains, in which we analyze all the steps an individual has gone through to get there. And we stop and realize, hey, when you left work, you had options. So one of your options was to go straight home. Another option was to go to the gym. Another option is to go into a store. Let's take one of those options. Let's say going to the store. You then had other options, which are to, hey, I'm going to go buy myself some kind of candy bar, or I'm going to buy myself a bag of grapes. You have those choices. And if we can start to analyze the thought process that goes into it, we're going to influence the direction somebody is like to go in. And when they get home, what are we going to go to for the snack? Are we going to go for, the chocolate? Are we going to go for the grape? Are we going to go for a protein bar? And if you can stop and analyze the thoughts each point along the way, we have a chance of shifting behavior. Cognitive behavior therapy has been found to be incredibly useful with weight loss in general, as well as helping to decrease depression, anxiety, and improve lots of character issues that have come up with individuals over the years. One of the things that's really powerful about cognitive therapy is that it is empirically founded. This is based on research. All these things get studied over and over again. A more recent type is called acceptance and commitment therapy, which which basically says we shouldn't always be fighting our feelings. We've got to learn to accept things. And I think this is one of the key things I'd love people to try to think about, to accept your situation a bit and to accept your feelings for being what they are, to analyze them a little bit from a distance rather than getting so caught up with them, and then say, that's an interesting thought. What should I do about that? And then when you start to create a little emotional distance, we're then able to say, oh, there are many ways we can act. And it's really helpful to speak to, people like yourselves who are experts in dealing with weight loss, or somebody like myself, or a dietitian who's got expertise in trying to help people think of creative ways. I got to tell you, one of the things I love to encourage people to go for are things such as protein bars or protein drinks, so that they get to the sense that they can have something that is both healthy for them and delicious. You don't have to give one up over the other. And that's where I think people get lost, with diets. And if we can start to shift the thoughts about healthy eating, and again, not just towards weight loss, towards increased health, we're going to do better. One last point. When I see people come in, oftentimes they talk about how they ate really badly the day before, or I had a bad week, or I was like, I had, bad meal. I was like, well, until proven otherwise, I don't think there's any bad food. Until I hear that a food has committed arson or has robbed a bank, the food isn't bad. Now, I've had food that's gone bad in the refrigerator, but that's a different situation over time.
I think that's a great point, right? You're trying to minimize, you're trying to stop that assignment of good and bad. Like already you're feeling bad about yourself because you had something bad.
That's it.
The assignment of blame, I think, is really hard. And I always do exactly what you say, which is the fact that a patient comes to see you. I'm like, you've just done the first step. So just take away all the blame of, oh my God, I've gained all this weight, or, oh my God, I need to do all this weight. The fact that they've come to see you is sort of the first step to sort of a new being, a new life, a new whatever they want it to be. So there's loads of ways to encourage them to do this. And I completely agree with sort of breaking the cycle, breaking the habits, find out what is it that motivates them, what is it that sort of helps them gain weight, and try and break that.
There's a great segue actually to our next segment, because this is, no one works in a silo, right? Like Paul's not working by himself. Reem, you're not working by yourself. Of course, one important part of our team is missing. Our dietitians I didn't get another person to come in. But, when we do weight loss, we actually work in teams all the time. We're very collaborative. And it's so important to have that behavioral change associated with our procedures so that patients can continue to be successful. Because one procedure, it's not you do it and you're done. It's really just the surgery or procedure can be the start of your journey, and not the whole journey. The journey will continue, and it has to be with behavioral change. Reem, you and I both do procedures. I do surgeries for weight loss. But we want to talk a little bit about some of the stuff that you do, which is endoscopic. And I want to start with the intragastric balloon. And this is something that's placed. This is just a recent spotlight, and I have a couple of slides from this article on the intragastric balloon and what it does. Can you just talk about it a little bit? And it is an FDA approved. It's also available in Europe and Latin America. I think all over the world, actually, the balloon is available. And you talk about it a little bit.
So thank you. There are currently 2 FDA approved balloons, and I think 2 more in the pipeline. 3 FDA balloons. One's been voluntarily withdrawn off the market. The 2 that are available are one is placed and removed endoscopically, and it's filled with saline. And it's a very safe, easy procedure. You go to your gastroenterologist, you have a balloon inserted, and it's sort of a 10-15 minute procedure. The way the balloon works is that it sits in your stomach. It occupies sort of a portion of your stomach, and it's filled with saline, so it makes you feel full. And at the beginning, it makes you feel a little nauseous, what we call the accommodative symptoms. But it delays gastric emptying, so food stays in there longer, and you're not able to eat the amount of food that you eat normally. And so because of that, you lose the weight. Now, the balloons stay in for about 6 months, and then you remove them. So throughout those 6 months, you're doing what Paul was saying. You're learning how to eat. You're learning how to eat well, because once the balloon is removed, you really are left to your own vices. And so throughout those 6 months, we get our patients to see a nutritionist, to see a psychologist like Paul, and to see someone who helps them learn how to eat well, exercise, do all the things that will sort of motivate them down the line. And the weight loss you get is about 10% of your total body weight. Some people lose more weight than that. Some people lose less. And at the end of the 6 months, you remove the balloon endoscopically. Now, the other balloon you place via X-ray, so you don't have an endoscope, but then again, you remove them endoscopically. And there are newer balloons down the pipeline that are also placed by swallowing the capsule, and you fill that with saline, and then the balloon sort of deflates in your system and passes itself spontaneously. And so you don't even need an endoscopy for it. So there's lots of balloons out there with similar weight loss between all types of balloons. And the key thing with this is a very safe balloon. And you can use this to sort of jumpstart your weight loss.
Yeah, I want to talk about this too. I think this is important because this was also, the AGA stands for the American Okay, you do it.
So the American Gastroenterology Association, it's our main main GI society, or one of the main ones.
I always think in dodgeball, the American Association.
I know you Google it sometimes. If you Google it, some gas company sometimes comes up. So, but it's basically just past evidence that there's level 1 evidence for intragastric balloon and weight loss, and intragastric balloon with improvement in comorbidities such as fatty liver and NASH. And since the fact that we've now treated Hep C, fatty liver is one of the biggest causes for liver cirrhosis, and something as simple as a balloon can help reduce that, can give you weight loss and improve your liver test, liver function, fatty liver, and so improve your comorbidities down the line.
Right. So that's what this slide is showing, how losing 10% of total body weight can really improve your heart health, and the hemoglobin A1C we're referring to is a measure for diabetes and how well you are treating your diabetes, and you can have reductions in your hemoglobin A1C into the normal range, even depending on how long you've had diabetes, et cetera. Exactly. And that last picture is of the liver, and you can have NAFLD stats for non-alcoholic fatty liver disease, but it's also known as NASH, or non-alcoholic steatohepatitis. And so you can see improvements in all these conditions with 10% weight loss. And the other things that's not mentioned on this slide really is you can have improvements in sleep apnea. You can have improvements in cholesterol as well. So, and joint disease. People. I think the unsung beauty or benefit of weight loss is how people's joints feel. Right? I have patients come in and they're like, I put up 5 pounds. I'm like, okay, it's not bad. She goes, no, my knee is killing me now. Like those 5 pounds, my knee feels. And the interesting thing for our listeners and our viewers might be that when you lose a pound, it's like losing 3 or 4 pounds on your knee and up to 9 pounds on your ankle. So weight loss really affects joints and the pain that patients can experience. So it's really a very good thing. Paul.
Yeah, I often use it as an example, like you're carrying 2 shopping bags the entire time. So once you lose that, you're sort of walking freely. So absolutely.
I comment on this all the time. So, sometimes people bemoan the fact I've only lost 20 pounds. I'm like, I don't know how you put only and 20-pound weight loss in the same sentence, but people do because they're comparing themselves to somebody who lost 50. But I use the exact same thing that you do, Marina. I say, do you understand that there's 4 times the pressure on your knees. So you've actually taken 80 pounds of pressure off your joints. You lose 50 pounds, you've lost 200 pounds of pressure. And that somehow has tremendous meaning. One of the things that I think that's important too, I let them know that most physicians are looking to see significant change in health improvement. It really starts at 5% of body weight loss. It doesn't even have to be 10%. 10% is a better result that Reem's talking about from the balloon procedures, but we start to get to 5%, and that's very meaningful. So they don't have to feel like I've got to lose, 30% before I'm going to start to get benefits.
Yeah, but it's also interesting. One of those slides from the AGA, we're talking about really how it's important to be in a program, right? Like I've been saying, it's not just about our procedures, but it's seeing somebody, weight loss maintenance, and then having a weight loss strategy. The thing about the balloon is, in this country, those balloons are usually out of your system in within 6 months, 4 months. But after you take it out, we have to figure out how to help the patient keep that weight off. And so that's one of the things where we encourage them to be in a weight management program, or in a support group, or seeing a behavioral specialist such as yourself, Paul. How have you guys managed that endoscopic component at Brigham and Women's? And we have wonderful colleagues there, all of us, actually, Reem and I both, that we know quite well, that do a lot of endoscopic procedures to treat obesity.
Yeah, it's actually been fascinating, because when I came to Brigham and Women's 8.5 years ago, I was the first behavioral health specialist, the first psychologist ever truly embedded in a surgical program. And I was kind of brought in to create a behavioral piece for the bariatric surgery program. And I started doing that, and suddenly surgeons who were really scratching their head dealing with some of the emotional and behavioral issues with some of the patients, all of a sudden they were able to stop worrying about that so much and focus on what they really did well, which was surgery. And then I was at a conference I spoke at, and one of my colleagues in the endoscopic world was there, Dr. Thompson, and he's like, wow, this is really good stuff. We should have you see our patients. So lo and behold, I started seeing the endoscopic patients, and then the obesity medicine folks started saying, oh, you should see ours. So I've started doing working with all the patients that we see.
All the arms,
exactly. And we are one unified program, which is really exciting. And so, I have great appreciation for the medications, for the endoscopic treatments, and for the surgical approaches. And people who know me know I'm really fond of the people that I work with. Marina, you know this incredibly well, and really respect your talents. One thing, though, that I think unites everything is always going to be behavior. Because it doesn't matter what you're doing. If it's a pill you have to take, well, you got to make sure you're taking your pills on time, or at the right order. Or if it's having an endoscopic approach, you're going to have to still engage in dramatic. It's not the balloon's going to do everything for you. You're going to feel more satiety, but you still have to stay hydrated. You still have to get in your protein, in a better way. You have to choose which foods you're going to take in that are going to bring you best health and weight loss, and certainly surgically. We see all those things. So for every one of the areas, the approach is incredibly similar. We start off by trying to first figure out, why does a person want to lose weight? Why does a person want to get healthier? Motivation is always going to be the key reason that somebody's going to follow through. It's easy to get people to come in sometimes. It's hard to get them to follow through. And so one of the things that I spend a lot of time on is getting to know an individual and find out, what do you hope to get out of this? Certainly weight loss is something everybody talks about, but it's weight loss for what purpose? Somebody who wants to, has a wedding coming up, and they want to look good at a wedding, or they're having difficulty with getting down on the floor. These things are meaningful because weight loss is going to be finite. But the ability to keep developing a new why, a new reason, please, that goes on and on forever. So we do that. Try to help them get assistance with whatever they're trying to do. Engage people in their family, ideally, or whoever they live with, to try to at least support what they're trying to do. And again, we take things slowly. We do not rush anybody to any of these procedures.
I want to say, I think you're just fantastic, and these are such fabulous points. One of our our viewers just posted that she had lost weight and she thought her aches and pains were from the weight. And when she lost more than 10%, she still had them. And I just wanted to comment about that because, unfortunately, sometimes we do have underlying joint disease. I hurt my knee skiing and I know it's arthritis. And also, you said dancing. I can't jump dance anymore because the next day I can't walk, right? Like I can't be like, it's just not going to happen. So unfortunately, there is some underlying issues that can happen with our joints that can still have pain. But for the most part, losing weight will at least make that pain a little bit better. And then I'm smiling so much because my wonderful co-host Sujana is not here, but she posed a question. She's so stealthy. She's in the middle. She's quite a big muckety muck in the ENT world, and so she's moderating a session and could not be here today. But she wrote, "Is there an amount of exercise or weight loss that you advise before going for a procedure?" I have my answer. What about you, Reem?
So I know with bariatric surgery, you require them to see, for insurance purposes, a dietitian or a weight loss program for 6 months. With endoscopy, yeah. So with endoscopy, but with endoscopy, we don't necessarily get insurance to pay for it. So there's a little bit of a flip side to it. Some patients come to see you, they want something done now. And initially, sort of 8 years ago, when I started doing this, I would say, okay, let's do it now. But I realized then that that patients aren't necessarily ready for what might come next. So now we sort of delay the process by about a month or two, not really more than that, because I feel like when someone comes to see you, they've already built up that momentum to come see you. They don't really need to wait another 6 months to lose the weight. They've really gathered the courage to come see you, so they want something done now. So as long as when we see them, the nutritionist sees them, a psychologist or psychiatrist sees them, and they all feel that they're ready for the procedure, they understand what it entails, then they don't really need to do any sort of diet or weight loss before the procedure. But having said that, I always tell patients with obesity that come see me that I'm really only 5% of the journey. The rest is really you, and we need to make sure that you have the support you need, that you understand what the diet post-procedure entails and what the diet post-procedure entails. So sort of once you've gone on that modified diet and you're eating quote unquote regularly again, how you need to change that and what meal replacements mean, what introducing any form of exercise means. So we don't delay anything per se, but we just make sure that patients understand sort of what it entails to undergo a procedure.
And so for us, as you said, we do have to have patients go through some weight loss before procedures. We really do a hardcore, most of us surgeons do a hardcore 2-week or 1-week liquid diet before surgery, which is like protein shakes, but they can have broth, etc. And the reason we do that is to shrink the liver so we can get to the stomach. And so that is something that we do before the procedures. It's not an insurance requirement, but that we just do to, it's easier, as I tell the patients, it's easier for me to do the surgery, but it's also easier for them to walk around after the procedure, et cetera, once they've lost that weight. And that can be anywhere. I've had patients lose 5 pounds doing that 2-week liquid diet, and some have lost 30. So it's very interesting, but it's not a long-term solution, right? A liquid diet. Let me just run through the surgeries really quick for our viewers, because I actually want to go back to you. This show is really about you too, but since we're talking about weight loss and procedures, so I do surgery for patients who have about 100 pounds to lose, or 50 to 80 pounds with comorbid conditions like high blood pressure, sleep apnea, and diabetes. And one of the procedures that I do is the gastric banding, and it's not done as often as it used to be. And I think we have a slide. Yep, there's the lap band that's out there. But it is a device that can help patients. I've had many successful patients with this, that it goes around the stomach, and there's a little inflatable balloon on the inside. And when they come to the office, we inflate that and we make it cinch around that upper part of the stomach. And when it does that, it makes patients eat less. It helps long term. It is something that can stay in your body for a while. And I've had patients since I started my practice in 2000 that still have their bands. The other procedure that's actually fairly popular right now is the sleeve gastrectomy, and it's popular around the world. We take out part of the stomach. This is completely irreversible, and because you can't grow back your stomach. And what this operation will help patients lose a significant amount of weight, and it is, as I said, it's a permanent change. And then I want to talk about the last one, which is a gastric bypass. And in this one, we don't take anything out. We just reroute everything so that the pink or red, however you see that, is where the food travels. We create this little small stomach pouch, and the blue is bypassed, but still draining normally. And then the two join at that Y, which is why it's Cesar Roux is the one who created this operation originally for ulcer disease. And the Y part, once those two join, then the food gets more digested. So this is makes you eat less, and you also don't absorb everything. And the reason, I wanted to talk a little about the surgeries is that I can do all that, and everyone watching might be like, or listening might be like, wow, people are going to lose weight with that. But you see, it also comes to the long-term follow-up and making sure that you're that they are going through with some behavioral changes that are also important, right, Paul and Reem? Like actually, Reem, Paul sees our patients, as he's already said, after surgery, before surgery and after surgery, to help them maintain that weight loss. And Reem will also see our surgical patients for either complications, or if they're regaining weight, she can do additional procedures to try and, keep the stomach skinny, if you will, for either the bypass or the sleeve.
Yeah, absolutely. I think there are many ways. I think the other point that I always tell patients or people with obesity that come to see us is nothing is permanent. Everyone, any sort of modality, but with surgery, it lasts the longest. You lose the weight, you plateau, and then you start regaining the weight. And there are different ways of combating that weight regain, be it another surgery, endoscopy, where you retighten the sleeve or retighten the opening for the bypass, or adding medications, or doing a series of CBT, like you said, to sort of reset your thinking and eating habits. But yeah, it's sort of a 3 or 4-pronged approach. It's not on its own. And I think patients need to know this going into a procedure, that nothing is permanent. Everything, if you follow up, you'll have that lasting weight. But if you don't follow up, and even over time, just people regain weight. Just as we grow older, we gain weight, and it happens post everything.
So there's this great slide on the weight loss surgery has other benefits than just weight loss, right? It's helping diabetes and heart disease, but also, as you pointed out, with the gastric balloon, you can have benefits in cardiovascular disease and in the liver, and as well with diabetes. I want to talk about a procedure that Reem does. She happens to, all of our viewers, you guys are so lucky, because she has done the most of this procedure in the United States. I'm so proud of her, and it's quite a technical skill. I learned how to do it. I don't do it. It's a lot of work. It's a lot of work, but she's managed to make it very simple and very streamlined. And this is a procedure called the endoscopic sleeve gastroplasty. And Reem, why don't you discuss what's happening here?
So it's basically a procedure where you bring the stomach and sort of bunch it up together on one end. So instead of it looking like a big bag where food can fill in, you're cutting out half that by bunching it together like an accordion, so it looks a little bit like a sleeve or a banana. So we're copying the surgical sleeve that Marina just showed earlier. And it's a day procedure. You basically come to see us. You're under anesthesia, and we make the stuff. My husband always says it's sort of similar to going to the dentist and pulling out your tooth. It's a simple procedure in that regard. But what I do want to say is that even though it's simple, it has good benefits. We've been doing it now for 8 years, and you see good results with it. So we've just published our 5-year data, basically showing durability, and the weight loss at 5 years is about 15% total body weight loss. So a little bit more than the balloons, a little bit less than the surgical counterparts, which is what to be expected. You're not cutting anything. But essentially the way it works, instead of the stomach being like this, it's a lot smaller. So you eat less, you feel full, and that's essentially how you lose weight. And throughout the process, it's a little bit like that Pavlovian response that you mentioned earlier. Sort of, if you overeat, you get pain. So you realize that, okay, that was a bit too much. And I remember one of my first patients, she says, I always eat 3 meatballs, and now I can only eat 1.5 because I tried to eat more. I got pain, and that sort of reiterated the message that her stomach can't fit that much, and so she eats a lot less. We also, similar to the surgeries, I mean, I learned this from Marina, we looked at our data looking at diabetes and fatty liver, and you can see that not only do you lose weight, you also improve your A1C, which is a marker for diabetes, you improve your blood pressure, and you improve your fatty liver, as you can see in one of our latest studies.
Yeah, this is a great thing too. So I as a surgeon, I think that the holy grail for treating obesity, since obesity is so prevalent, is doing something less, right? So when we first started doing weight loss surgery, which was in the 60s, it was a big cut, and patients had a lot of wound issues, and it was hard to move around. And then we got to laparoscopy, and we were making very small incisions. And actually, I think laparoscopy and also robotics are a great way to do these procedures. I think patients are up and moving, but as you said, you're going through the mouth. There's no scar, so there's no physical pain from the muscle and the cuts and things like that. But there's going to be some discomfort, etc. And not to say that these procedures, even if you do them endoscopically, they're not without complications. They are. We're kind of giving you the highlight, like these are the great things that can happen with these, right? But it's so important that as we do endoscopic treatments, that the focus is not just on weight, but also on improvements in the fatty liver, as you mentioned, diabetes, hypertension. I mean, if you're keeping off 15% of your total body weight loss, total body weight, and you had high blood pressure, I think your high blood pressure could be, significantly improved at 5 years. So Reem has looked at not just the parameters we showed in that one study, but looked at all of them. And I think that that's important, that this is something that we all want to encourage and pursue for further weight loss. Paul, I have a question for you. Do you feel that your treatment of our surgical patients and how you counsel them has influenced how you counsel your non-surgical patients, or is it vice versa? Like, do you just, it's not the same message, right, all the time?
No, but the themes are the same. There's themes and variations. And since I really cut my teeth, so to speak, in surgery, which is where I've done most of my work, it was really those strategies that have been very helpful to apply to other areas. So yeah, I think it's not a real chicken or the egg. I started with surgery. I learned the strategies that are useful. I learned the value of, and these are the strategies that I employ myself because I've had weight struggles since I was young as well. So I'm a stickler for hydration and for protein and for physical activity and strength training. These are all things that are part of the bedrock of long-term success with bariatric surgery, but they are also the same things that we're going to find with an endoscopic approach or an obesity medicine approach. They all come together. And so, yeah, I think I started with surgery. I found them all to apply. One would think you'd start with the milder thing, but no, it's the more severe. And actually, if I go back even farther, when I was in training and getting my degree in clinical psychology, my dissertation was based on work in eating disorders. And I spent 2 years working on an eating disorders inpatient unit. And so that's where I really learned the emotional side of eating issues. And with obesity, we're seeing some of the opposite side of a similar coin, but we still see a lot of issues with control and body image, which is, something that we have to deal with in all of these procedures. And in terms of, what somebody chooses, we know that you're going to usually have more weight loss with surgery. You have that good weight loss. Surgery is certainly very good with the endoscopic approaches, and we should expect some reasonably good results also with medication. But I'm about getting somebody to do what they're willing to do, because anything that's going to promote health, I'm going to be in favor of, and I'm happy to work with all those areas.
Well, what you brought up medication, Reem brought up medication. I'm going to bring up medication now if I haven't already. So I have a slide on some of the different medications that we do use for weight loss, and this is what's currently available. Metformin is something that we give our patients who have diabetes, and so in some of those patients, it helps them to lose some weight. So sometimes, you see patients are started on that for weight loss. And there's a whole list here, and there are some that are off-label use, like some of the GLP-1 agonists like Saxenda and Trulicity. Actually, Saxenda is approved in the U.S. for weight loss, and it's a daily shot. But there's a bunch of others that are actually given for patients with diabetes, but they are so good at weight loss that it's actually something, that's helpful.
I think what you've touched upon is that there are so many medications that we use, and I'm part of the Eye Change Clinic, and I work with Dr. Aroni and our eye who does weight loss management. And our Eye Change is sort of a three-prong approach clinic where someone comes to see us and they have the different options for either seeing someone just for nutrition and dietary needs, our fatty liver specialist, and then our endocrinologist. And what I always ask a patient is, what is your advice? Do you have nighttime cravings? Do you feel like you need to eat during the day? Or are you just permanently hungry? And then, or you're never full. And based on that, there are different medications, some for craving, some for nighttime eating, and some for making you feel full, like the GLP-1s. And it's really important to sort of highlight the newest study, which is the Ozempic study, that New York Times called it a game changer, because in a sort of level 1 evidence, a randomized trial where they gave some patients the medication and some patients sort of a placebo effect, they had sort of nearly 15% total body weight loss, which is similar to what you would get with endoscopy and some of the surgeries. So it's really, there are medications that either used alone or in combination that can give you that weight loss. And remember what we said at the beginning, is that you really need to get some of the benefits is to just lose 10% of your total body weight. And so if some of the medications do that, then you don't need any procedures. So that's sort of the other facet to all of this.
It really is. I treat patients for medical weight loss, and I've had patients lose 30 to 50 pounds. And also my post-surgery patients who've gained weight, I'll sometimes put on meds, and they also lose the weight. And it has decreased the number of surgical revisions of procedures I've done. And I think it is so important to do both. We have about 2 minutes left. Can we give us some takeaways for our viewers and our listeners? Reem, you're first.
I guess there are multiple ways you can lose weight. There's really not a one-shot approach. You really need to, and I learned this from Marina, think of obesity as a chronic disease where it's with you for your lifetime, and you can't just put yourself to blame. And as Paul said, there's a genetic component to it. But just having you see someone that's a specialist for weight loss is that first step. And whatever method you choose, it's likely to be successful because it's the one you choose. And there are different approaches out there that we can help streamline, and we can help you lose that weight.
Paul?
I think I would say that, like Reem, that whatever you choose, hopefully you can get some success with. Certainly there's step levels that are more intensive, but regardless of what you choose, make sure you focus on the behavioral element, because that is the link to everything. I think it's important for people to remember that it's really our thoughts control our feelings. And if we can address that and accept them, we can shift them. Number two, motivation, motivation, motivation. As I tell people all the time, if you show me the why, I'll show you the how. And then lastly, accountability in whatever we do, being accountable and feeling comfortable to delegate people to help you with it and not feel bad or shame or guilt for seeking assistance. It's actually a sign of strength.
Well, thank you. You guys, we are out of time. I want to thank my wonderful guests, Reem Sharaiha, Paul Davidson. I want to thank our team. We've had a great production team behind us. And I didn't get to all the questions. You could watch this again live on YouTube. Next week, stay tuned. Sujana is going to do a show on allergies, and it's going to be fantastic.